Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite-sized pieces. Perfect for your commute, coffee break, or whenever curiosity calls. I'm Hayat, your host for this episode, and I'm joined by the one and only Nayaz.
Hey everyone, it's Nayaz and it's great to have you all with us. Today we'll be discussing an important topic in dermatology and pathology, tumors of the skin.
1 second. How important is this topic anyways?
The thing about skin lesions is that not only are they extremely common in clinical practice, but they also range from completely harmless to being pretty dangerous by carrying a genuine risk for some of the most common malignancies worldwide.
Oh, it seems like a pretty serious topic.
It really is, and our goal today is to break down how these tumors present, what they look like clinically, how they appear under the microscope, and how to distinguish benign, premalignant, and malignant lesions from one another. Are we ready?
One more thing, Nayaz. How can you tell that a lesion is quote-unquote just a chill guy and benign and not a malignant tumor?
Benign skin tumors stay localized, don't invade surrounding tissue aggressively, and in most cases, they pose a cosmetic issue more than a medical threat. Some benign skin tumors are seborrheic keratosis, dermatofibromas, and epidermoid cysts. Now for malignant tumors, let's just leave the final boss till the end.
Sure thing. Let's start with the benign skin tumors by introducing our first patient. Our first patient is the 62-year-old man that came to the clinic because he noticed several tan to dark, slightly raised spots on his chest and back. They're not painful, they're not bleeding, and he mainly came in because they just look weird. On examination, they have a waxy appearance and genuinely look like someone just stuck them onto the skin. So Nayaz, with that description, what's the most likely diagnosis?
This is classical for seborrheic keratosis, especially with the stuck-on look. These are very common benign epithelial tumors that usually appear in middle-aged and older adults. They can be tan, brown, or even darker. They have the waxy or velvety surface that makes them stand out. A nice mnemonic I use for these clinical presentation is SORT. S is for stuck on, O is for older adults, R is for raised spots, and T is for tan appearance.
Amazing. Now, when we say benign, we mean it grows slowly and basically never becomes malignant, right?
Exactly. Seborrheic keratosis don't transform into cancer. They just annoy people cosmetically. One important detail, in darker skin types, you can see multiple small lesions on the face, and that variant is called dermatosis papulosa nigra.
On the face? I can see why they annoy people now, especially with that stuck-on look you spoke about. This makes me wonder, why do they have that appearance?
It's related to how the lesion grows. Histologically, seborrheic keratosis consists of sheets of basaloid cells that pile up and grow outward from the skin. There are also horn cysts, which are little keratin-filled cystic spaces. A simple analogy is like dried candle wax that forms small droplets and layers. It sits on top of the surface rather than blending into it.
I like that analogy. Now, what about the molecular cause?
Many seborrheic keratosis have activating mutations in the fibroblast growth factor receptor 3 gene, aka FGFR3, a growth factor receptor that signals through pathways like RAS and PI3K/AKT. These mutations drive the proliferations of those basaloid cells. But even with these mutations, the growth is not that crazy and manages to stay controlled, which is why the lesion remains benign.
Before we move on, there's that exam favorite point about the sudden appearance of multiple seborrheic keratosis. Can you explain that?
I was waiting for that. That's basically called the laser trila sign. So if someone suddenly develops a large number of seborrheic keratosis, it can be a paraneoplastic phenomenon associated with internal malignancies, especially gastrointestinal adenocarcinoma. The idea is that the tumor produces growth factors that trigger these eruptions. So even though seborrheic keratosis itself is benign, this pattern should not be ignored.
And to wrap up seborrheic keratosis, how are they usually managed?
Most of the time, no treatment is needed. But if the patient wants them removed for cosmetic reasons or if they get irritated, you can freeze it by cryotherapy, scoop it out by curettage, or heat it to death by electrocautery.
So now that we're done with seborrheic keratosis, let's move on to our next benign condition with the case. Our case is a 19-year-old woman comes in because she noticed darkening and thickening of the skin around her neck. She says it looks dirty, but washing or scrubbing doesn't change it. On examination, the skin in her neck folds is hyperpigmented, velvety, and slightly raised.
That's acanthosis nigricans. It shows up as thickened, hyperpigmented, velvety skin, usually in flexure areas like the neck, axilla, groin, and sometimes the anogenital region.
Oh, and this one has both a benign form and a malignant form, right?
Exactly. The benign type is about 4 times more common. You see it in children, teenagers, or young adults. often associated with obesity, insulin resistance, and diabetes. The malignant type is less common and appears in older adults. It's associated with internal malignancies, especially gastrointestinal adenocarcinoma. When it appears suddenly and extensively in someone who isn't overweight, that's a big red flag.
And histologically, what's happening in acanthosis nigricans? Why does it look and feel the way it does?
Histologically, you see hyperkeratosis and epidermal hyperplasia, with the dermapapilla forming those undulating wave-like peaks and valleys. To visualize, it is like gently pushing a rug from underneath, giving you that raised surface that trips over your siblings, and it's exactly like that. There's also some increased pigmentation in the basal layer, but it's not a true melanocytic hyperplasia. The thickening of the skin is what gives the velvety appearance.
You did mention that it's associated with insulin resistance. Why is that the case?
When insulin levels are high, which we see in insulin resistance, insulin can bind to IGF-1 receptors in the skin. This stimulates keratinocyte and dermal fibroblast growth, leading to the thickened appearance.
So clinically, where does acanthosis nigricans fit in our classification today? Benign tumor or malignant tumor?
I mean, it's not a tumor in the neoplastic sense. It's more of a reactive epidermal change. But because it presents as a distinct recognizable skin lesion and often appears alongside the benign tumors we've been discussing, it's commonly included in the benign category for teaching purposes.
All right. And in terms of management, what can we do?
The most important part is addressing the underlying cause. For benign cases, losing weight and controlling the diabetes usually does the trick. For malignant cases, we try identifying and treating the underlying cancer. Topical treatments don't really remove it, but keratolytic agents like urea or retinoids can soften the thickened skin.
Great. Let's look at another common benign lesion. Our case is a 45-year-old man that came into the clinic for a general checkup. While examining him, you notice a few small, soft, skin-colored growths hanging from thin stalks of his neck and in his axilla. He says that they don't hurt, and he's had them for years, but more seem to be appearing as he gets older. Nayaz, what does that sound like?
That's a typical presentation of fibroepithelium polyp, also known as skin tag, or acrocordon. They're extremely common, especially in middle-aged or older adults, and they tend to appear in areas of friction like the neck, axilla, groin, and beneath the breasts.
Clinically, they're pretty recognizable, soft, pedunculated, and usually flesh-colored. But what's actually inside these?
Histologically, they're made of a fibrovascular core, meaning connective tissue with small blood vessels, covered by completely normal squamous epithelium. So it's not a neoplasm in the dangerous sense. It's more like a tag of skin that got stretched and elongated. A simple analogy is imagining a tiny tent pole, or the fibrovascular core, covered with a thin sheet, the epidermis.
What about risk factors or associations? I know some conditions make them more common.
Yes, skin tags tend to be more frequent in people with obesity and diabetes, likely due to friction and possibly mild insulin resistance. They can also be seen in pregnancy because of hormonal effects. And even though it's rare, they have been associated with intestinal polyposis syndromes. So multiple skin tags in a younger person could warrant a closer look.
Do they ever turn malignant or cause any serious problems?
Not on their own. They're benign and don't transform. The only issue is if they get irritated, twisted, or inflamed, which can cause pain or redness. Otherwise, they're harmless.
So how do we manage them?
If the patient wants them removed, usually for cosmetic reasons or because they get irritated, you can treat to them with snip excision, cryotherapy, electrocautery, but medically, removal isn't necessary.
Let's keep powering through these benign lesions, and on to the next one. Our case is a 32-year-old woman that came in concerned about a small bump on her lower leg. She says it's been there for months, maybe even years, and it doesn't really hurt unless she presses on it. On examination, you find a firm, small, brownish nodule about 6 or 7 millimeters in diameter. And when you gently pinch the skin around it, the center seems to dimple inwards. Nayaz, what diagnosis does this point towards?
That classic dimple sign you just described is almost always seen in dermatofibroma. It's a benign dermal tumor made up of fibrohistocytic cells, and it tends to occur more often in women, especially on the legs.
So the firmness and the dimple sign are the big clues clinically. Why does pinching make it dimple inward?
It's because the lesion is anchored firmly in the dermis. When you pinch the surrounding skin, the lesion gets pulled downward instead of lifting up like softer lesions would. Imagine a button sewn tightly onto fabric. If you pinch the fabric around it, the button sinks inward instead of coming with the fold.
Nice analogy. What does the lesion look like under the microscope?
Histologically, dermatofibromas show a proliferation of spindle-shaped fibroblasts and histocytes in the dermis. The overlying epidermis can be slightly thickened. The key point is that the growth is localized and well contained, without any invasive or atypical features that would raise any concern for malignancy.
Clinically, do we know what causes them? Patients often ask if it's related to trauma.
The exact cause isn't fully known, but trauma has been proposed as a trigger in some cases, possibly insect bites or minor skin injuries. The theory is that the lesion represents a localized reactive process rather than a true neoplasm.
And in terms of management, do we usually need to remove them?
Not unless they're symptomatic or bothering the patient. Dermatofibromas are benign, stable, and rarely cause problems. If removal is desired for cosmetic reasons or persistent symptoms, they can be surgically excised. But you need to take enough tissue because they extend fairly deep into the dermis. Remember, the buttons sewn tightly onto fabric.
We've got more benign lesions coming up, so don't fall asleep just yet. Our next case is a 28-year-old man who came in because he has a lump on his upper back. He says it's been there for years, but recently became tender and a little red. On examination, you feel a round, firm, mobile subcutaneous nodule about 2 centimeters in size. Right in the center, there's a small black dot, almost like a tiny pore. When you press around it, a bit of thick, cheesy material comes out.
That's a classical epidermoid cyst, sometimes incorrectly called a sebaceous cyst. The central punctum you mentioned is the giveaway. It represents the opening of the cyst to the skin surface.
So what exactly is inside these cysts? Patients always think it's pus.
Right? But it's not pus. It's keratin debris. This thick, cheesy material made of dead squamous cells. Imagine a tiny balloon cyst lined with squamous epithelium and filled with flakes of keratin instead of air. When the cyst ruptures or gets inflamed, the body reacts to keratin like it's a foreign substance, which is why it becomes painful or red.
Why do these cysts form in the first place?
They form when epidermal cells get trapped in the dermis. They continue producing keratin. But because the cells are enclosed, the keratin accumulates inside a cyst wall lined by stratified squamous epithelium. They can arise spontaneously after trauma or from a blocked hair follicle.
Let's connect that to histology. What does an epidermoid cyst look like under the microscope?
Under the microscope, you see a cystic structure lined by normal stratified squamous epithelium, complete with a granular layer, and the lumen is filled with laminated keratin. This is what separates it from other cyst types, like pillar cysts, which lack a granular layer.
An epidermoid cyst is lined by stratified squamous epithelium and a granular layer, and it's filled with keratin. You mentioned earlier that they can get inflamed. How does that happen?
If the cyst ruptures, even partially, the keratin spills into the dermis. The immune system reacts strongly to the keratin in the dermis, leading to granulomatous inflammation. Clinically, it looks like an infection, but often it's just a sterile inflammatory response.
So when should we treat or remove these?
If they're asymptomatic, you can leave them alone. But if they're repeatedly inflamed, infected, or bothering the patient, the best treatment is complete surgical excision, making sure to remove the entire cyst wall because if you don't, the cyst can reoccur.
We have made it to the last benign disorder. Should we take a new case?
Let's do it!
Our next case is a 14-year-old boy that came into the clinic with a rapidly growing red bump on his finger. He says it started as a tiny spot a few weeks ago, but now it's about 1 centimeter and it bleeds extremely easily. Even light contact makes it ooze. On examination, you see a bright red, soft, pedunculated nodule with a moist surface.
That's very typical for pyogenic granuloma, which, by the way, is a misleading name. It's not actually pyogenic and not truly a granuloma. It's a lobular capillary hemangioma, meaning it's a benign overgrowth of small blood vessels.
That explains the bleeding. They seem to ooze with the slightest touch. Why do they bleed so much?
Because they're made of proliferating capillaries, arranged in lobules. The surface is thin and fragile, so even mild trauma can cause brisk bleeding. It's like a cluster of new baby capillaries that haven't fully matured, delicate and easily disrupted.
What causes them? They seem to just pop out of nowhere sometimes.
They're often triggered by minor trauma, irritation, or friction. In children and teenagers, they're common on fingers and lips. They can also appear during pregnancy, called pregnancy tumors, usually on the gums, due to hormonal influence combined with local irritation.
I'm guessing we see a lot of capillaries on microscopy.
Yep, histology shows lobular aggregates of capillaries within edematous stroma. The overlying epidermis can ulcerate, which contributes to the bleeding. The key feature is the lobular architecture, which differentiates it from other vascular lesions.
So pyogenic granuloma is lobular aggregates of capillaries that bleed easily. It's benign, but it grows fast, which tends to freak patients out.
Exactly. The rapid growth is what concerns people, but it's still benign and non-invasive. The speed is just due to the vascular proliferation.
And how do we manage pyogenic granuloma?
Management usually involves shave excision with cauterization of the base to prevent recurrence, since these lesions can come back if the vascular core isn't treated. Occasionally, cryotherapy or laser therapy can be used.
All right, before we move on, let's run through a few quick questions that focus on the specific identifying features of the benign lesions we discussed. Ready, Nayaz?
Go ahead.
Which benign lesion is characterized by horn cysts and proliferation of basaloid cells, giving it that classic waxy stuck-on appearance?
That's seborrheic keratosis. Horn cysts are the signature histological feature.
Which lesion has a soft, pedunculated appearance and is composed histologically of fibrovascular core covered by normal squamous epithelium?
That describes a fibroepithelial polyp, or skin tag.
Which benign lesion shows spindle-shaped fibroblasts and histiocyte in the dermis and clinically demonstrates a positive dimple sign?
That's a dermatofibroma. The dimple sign and the dermal spindle cells go together.
Which lesion is lined by stratified squamous epithelium with a granular layer and filled with laminated keratin debris, often discharging through a central punctum?
That's an epidermoid cyst.
And which lesion consists of lobular proliferations of capillaries, grows rapidly, and bleeds with minimal trauma?
That's a pyogenic granuloma, also known as lobular capillary hemangioma.
Great. That covers the core distinguishing features we need to remember.
Exactly. With the benign lesions done, we can now move forward to the next group of lesions.
We've covered the benign tumors. Now let's shift into the next category, premalignant lesions. These are lesions that haven't become cancer yet, but have the potential to progress if left untreated. They sit in that middle zone, not harmless, but not fully malignant either.
In the skin, the most important premalignant lesion we focus on is actinic keratosis. It represents early dysplastic changes in keratinocytes, caused mainly by chronic ultraviolet exposure. These lesions are essentially warning signs that the skin has sustained enough damage to start developing abnormal premalignant growth.
So the key idea here is that the cells are already showing atypia, but that atypia is still confined to the lower layers of the epidermis. Once the atypia extends through the full thickness of the epidermis or breaks into the dermis, we're talking about squamous cell carcinoma.
Right, that's why recognizing premalignant lesions matters. Actinic keratosis exists on the same spectrum as squamous cell carcinoma, just at an earlier reversible stage. Early treatments can prevent progression into cancer.
And clinically, these lesions tend to appear on sun-exposed skin, especially in older individuals or those with fair skin types.
Exactly. They show up on the scalp, face, ears, and backs of the hands, basically anywhere that's seen years of sunlight. That chronic UV exposure is what drives the cellular damage and mutations we'll talk about in a moment.
All right, with that context in mind, let's get into the most important premalignant lesion. Our case is a 71-year-old man who spends a lot of time outdoors, comes in for a routine exam. On the top of his scalp, where he has thinning hair, you notice several rough, scaly patches. When you run your finger over them, they feel like sandpaper. He says they're sometimes itchy, but not painful.
That fits perfectly with actinic keratosis. These are premalignant lesions caused by chronic sun exposure, especially in older adults. With fair skin, the sandpaper texture is one of the most characteristic findings.
Clinically, they look like small, scaly, erythematous or brownish patches, but the feel of the lesion is often the most helpful clue.
Absolutely. Sometimes the visual appearance can be subtle, but once you palpate it, the roughness stands out immediately. They're typically less than a centimeter in size and often appear on sun-exposed areas, scalp, face, ears, forearms, and the backs of the hands.
Let's talk about what's actually happening at the cellular level. Why is this considered premalignant?
Actinic keratosis represents dysplasia of the basal layer of the epidermis. These keratinocytes show atypia, but the atypia is partial thickness, meaning it hasn't involved the full epidermis yet, and it definitely hasn't invaded dermis. It's basically the first step on the spectrum leading towards squamous cell carcinoma.
And histologically, what features define actinic keratosis?
You'll see basal cell atypia, parakeratosis, which is the stratum corneum with nuclei, when it's normally dead cells, and hyperkeratosis, which is excessive production of keratin. One important finding is solar elastosis in the dermis, which basically means degeneration of collagen from chronic UV exposure. If you imagine collagen fibers as long, tidy ropes, solar elastosis is like those ropes becoming frayed, tangled, and clumped due to years of UV damage.
It makes the elastosis concept easier to visualize. So in actinic keratosis, we see basal cell atypia, parakeratosis, hyperkeratosis, and solar elastosis. It may progress to squamous cell carcinoma, but how big is the risk of progression?
About 1% per lesion per year on average, but the more lesions there are, the higher the cumulative risk. Sometimes there can be lesions on the lips called actinic cheilitis. Those have an even bigger risk.
How do we typically manage actinic keratosis?
There are several options. For individual lesions, cryotherapy is the most commonly used treatment method. For multiple lesions or field damage, we can use topical 5-fluorouracil, imiquimod, or photodynamic therapy. The goal is to treat the dysplasia before it progresses into full-blown cancer.
So, in summary, when you see a scaly, rough lesion in a sun-exposed area and biopsy shows dysplastic basal keratinocytes, you must immediately think of the premalignant lesion, actinic keratosis.
Exactly. And understanding this helps set the stage for our next category, the malignant tumors.
Before we move on to the malignant tumors, let's test one key point about actinic keratosis. Here's the question. Nayaz, which specific histological feature is the most characteristic for actinic keratosis and helps distinguish it from both benign lesions and full-thickness squamous cell carcinoma in situ?
The hallmark histologic feature of actinic keratosis is partial thickness atypia, limited mainly to the basal layer of the epidermis. You'll also see hyperkeratosis, parakeratosis, and solar elastosis in the dermis. But the key distinguishing feature is that the atypia does not involve the full thickness of the epidermis. That's what separates it from carcinoma in situ.
I hope you're still awake because now we'll jump into the most important category of today's episode, malignant skin tumors. These are lesions in which the cells have acquired enough atypia and invasive potential to break through normal boundaries and behave aggressively.
In dermatopathology, the two major malignant skin tumors we focus on are squamous cell carcinoma and basal cell carcinoma. They're both common, especially in older adults with chronic sun exposure, but they behave very differently.
One key difference is their biological behavior. Squamous cell carcinoma has a real potential for local invasion and metastasis, while basal cell carcinoma almost never metastasizes but can be locally destructive if ignored.
And both develop through the accumulation of DNA damage, most commonly from ultraviolet radiation. That's why we see them predominantly in sun-exposed areas like the face, ears, scalp, and dorsal hands.
The clinical appearance of these malignant lesions is tied directly to their histology. Squamous lesions show keratinization, giving thick, crusted surfaces, while basal tumors form smooth, pearly papules with visible telangiectasis.
Yes, squamous is crusty while basal is pearly.
All right, with that foundation set, let's dive into our first malignant tumor, squamous cell carcinoma. Our patient is a 74-year-old man with a long history of sun exposure, comes in with a lesion on top of his ear. He says it started as a rough patch a few months ago, but it's grown, become thicker, and recently started crusting and occasionally bleeding. On exam, you see a firm hyperkeratotic red nodule with a rough, scaly surface and some central crusting.
That's very suggestive for squamous cell carcinoma, or SCC. The crusty hyperkeratotic surface and the firmness of the lesion in a sun-exposed area are classical clues.
Let's break down why SCC looks this way. What are the driving factors behind it?
The biggest risk factor is cumulative ultraviolet exposure, especially UVB. That leads to DNA mutations, particularly in the p53 tumor suppressor gene. Other contributors include chronic wounds or scars, immunosuppression, arsenic exposure, and HPV infection, especially type 16 and 18 in mucosal sites. But in the sun-exposed skin, UV damage is by far the main cause.
And the lesion's crusted surface. That ties back to the tumor's origin, right?
Right. SCC arises from squamous keratinocytes. and squamous cells love to produce keratin. So clinically, you get thick, rough, scaly, crusty, and uneven surface with a firm, indurated base. Keratin production by the squamous cells is key.
What does SCC look like under the microscope?
You see atypical squamous cells invading the dermis. In well-differentiated SCC, you'll find keratin pearls, circular whorls of keratinizing cells. There are also intercellular bridges, which are desmosomal attachments between squamous cells. Poorly differentiated SCC might lose these classical features, and we may need immunohistochemistry to confirm the diagnosis.
Any squamous cell carcinoma anywhere in the body has atypical squamous cells, keratin pearls, and intercellular bridges. Now, something important. Does SCC metastasize?
Yes, unlike basal cell carcinoma, SCC can metastasize, though the risk varies. About 5% of cutaneous SCCs metastasize, but the risk is higher in some patients, specifically those with lesions on the lips or ears, immunosuppressant patients, or those with tumors arising in scars or chronic ulcers.
And treatment?
The main treatment is surgical excision, with adequate margins. Mohs micrographic surgery is preferred for high-risk areas like the face, ears, or lips. Radiation is an option for patients who can't undergo surgery.
Great. SCC is all about keratinization, crusting, sun exposure, and the potential for metastasis.
Exactly.
And now we can move on to the next malignant tumor, which behaves very differently. Our patient is a 68-year-old woman that came in because she noticed a small bump on the side of her nose. She says it started as a tiny, pearly spot months ago and has been slowly getting bigger. On examination, you see a smooth, shiny, pearly papule with fine surface telangiectasis. In the center, there's a slight depression, almost like a tiny ulcer starting to form.
That's classic for basal cell carcinoma, or BCC. The pearly appearance with visible telangiectasis, especially on the face, is one of the strongest clues.
And BCC is the most common skin cancer overall, right?
Precisely. It's actually the most common cancer in humans. It occurs mostly in older adults and overwhelmingly in areas of chronic sun exposure, like the face, nose, and eyelids.
Since BCC is related to sun exposure, I'm guessing that's also due to UV-induced DNA damage?
Definitely. The central mechanism is UV-induced DNA damage, particularly affecting the PTCH1 gene, which is a key regulator for the hedgehog signaling pathway. When PTCH1 is mutated, the pathway becomes overactive, leading to uncontrolled proliferation of basal cells.
So hold on, the UV damages DNA, leading to an overactive hedgehog signaling pathway, and this is what makes the basal cells divide like crazy.
You're right. We also have a genetic syndrome called Gorlin syndrome, which has the same mutation, so patients with the syndrome get multiple BCCs at a young age along with jaw cysts.
With SCC, we said the surface is rough and crusted, but with BCC, it looks completely different. Smooth, shiny, pearly. Why is that?
The crustiness in SCC was due to keratin, but here in BCC, the basaloid cells form nests of uniform, dark basophilic cells that sit in the dermis. These basaloid nests are covered by a thin epidermis. When light reflects off this layer of epidermis, you see this pearly appearance, and the surface is smooth and translucent.
So SCC is rough sandpaper, while BCC is shiny pearl. And what is that central indentation or ulceration in BCC called?
We call that the rodent ulcer, a hallmark feature of nodular BCC. As the tumor grows downward, the surface can erode. Unlike SCC, this rodent ulcer in BCC has rolled pearly borders.
When it comes to the histology of BCC, what are some key microscopic features?
The two hallmark features of BCC are peripheral palisading and retraction artifact. Peripheral palisading is when the cells at the edge of the tumor nests line up like a row of fence posts. Retraction artifact is when there's a space between the tumor nests and the surrounding stroma. You'll also see a mucinous stromal background, which is another important feature.
So peripheral palisading, retraction artifact, and mucinous stromal background for BCC. Got it. We already said that SCC can metastasize, but does BCC metastasize?
Almost never. But BCC can be locally aggressive, especially the morpheoform or infiltrative types, which can invade deeper tissues, cartilage, and even bone if neglected.
Is it managed by surgical excision?
Management depends on the subtype and location, but yes, most are treated with surgical excision. For lesions on the face and high-risk areas, Mohs micrographic surgery gives the best tissue preservation and margin control, just like in SCC. Superficial BCCs can sometimes be treated with topical imiquimod or photodynamic therapy.
Perfect. So to summarize, BCC has this pearly papule with telangiectasis, palisading nuclei, and PTCH mutation.
100%.
Before we move on, let's go through 2 quick questions to reinforce the core distinguishing features of the malignant lesions. Which skin cancer shows palisading nuclei at the edge of the tumor nests and retraction artifacts separating the tumor from the surrounding stroma?
That's basal cell carcinoma. The combination of peripheral palisading and stromal retraction is very characteristic.
Between SCC and BCC, which one has a genuine risk of metastasis?
Squamous cell carcinoma. It can invade locally and metastasize, especially in high-risk locations or immunosuppressed patients. On the other hand, basal cell carcinoma almost never metastasizes.
All right, let's wrap up with a quick recap of everything we covered today. Starting with the benign lesions.
Seborrheic keratosis presents as a stuck-on, waxy lesion with basiloid cell proliferation and horn cysts. It's completely benign, but a sudden eruption of many lesions can be the laser trilor sign related to underlying malignancy.
Then we have acanthosis nigricans, a velvety, hyperpigmented thickening of flexural skin, most often linked to insulin resistance but occasionally associated with internal malignancy.
Next was the fibroepithelial polyp, or skin tag, a soft pedunculated lesion with a fibrovascular core, completely harmless unless irritated.
Dermatofibroma came after that, with a firm dermal nodule with the classic dimple sign and spindle cell proliferation in the dermis.
Then the epidermoid cyst, a subcutaneous nodule with a central punctum, filled with laminated keratin, lined by stratified squamous epithelium.
The last benign lesion was pyogenic granuloma, a bright, red, rapidly growing, easily bleeding nodule made of lobular capillary proliferation.
After benign lesions, we move to the premalignant stage with actinic keratosis, those rough, scaly, sandpaper-like patches on sun-exposed skin with partial thickness, basal atypia, and solar elastosis.
And then the malignant tumors. Squamous cell carcinoma showed up as a firm, crusted, hyperkeratotic lesion with keratin pearls and intercellular bridges, caused by cumulative UVB exposure and p53 mutations.
And a basal cell carcinoma presented as a pearly papule with telangiectasis, sometimes ulcerated with palisading nuclei and retraction artifacts on histology. It's locally invasive but rarely metastasizes.
Perfect. That covers the full spectrum of skin tumors, from benign, premalignant, and all the way to malignant lesions.
And understanding the clinical appearance along with the histology is what really ties all of these together.
And that brings us to the end of today's episode on skin tumors. If you ever feel unsure in practice or during exams, go back to the core features of texture, color, behavior, and histology.
And remember, early recognition of premalignant and malignant lesions can make a big difference in patient outcomes. Even benign lesions can sometimes tell a bigger story.
Thanks for joining us today. We hope this breakdown helps solidify the key concepts and distinctions within skin tumors.
Don't forget to wear your sunscreen, and we'll see you in the next episode of PodBites.